Greetings, ladies and gentlemen, and welcome to EDA's COVID-19 Education Forum. I'm your host, Jonathan Diaz, and today we're talking all things COVID-19. Our goal is to simply provide you with scientific-based evidence from a non-biased third-party expert. Today, I'm joined by principal owner of Clotting Corporation and vice president of health sciences. With over 20 years of experience, she holds a doctorate from Harvard University with a concentration in environmental health and occupational epidemiology. She also holds a Master of Science in Science Engineering from Dartmouth College and a Bachelor's of Science in Bioengineering from Syracuse University. Very tough to memorize, extremely long resume. Without any further ado, it's my honor and privilege to welcome Dr. Shannon Mcgarry.
Hi, John.
Hi, Shannon. How are you today?
Awesome.
We're glad to have you. So why don't we jump right into it? For the past 21 months, we've been dealing with a worldwide pandemic. Some of the talking points for today's segment will include a brief timeline from beginning to end, where we get some trusted sources of information, resources we have to help us control the pandemic, and then the science surrounding the COVID-19 disease and vaccines. So without any further speculation, let's dive right into it. So why don't we start at the beginning? Can you give us a breakdown of the pandemic, past and present, and where are you getting your information from? Where are these trusted sources? Where can we find them?
So again, John, we'll start with that background in the current situation. Next slide. Where is everyone getting their information? Where should they be getting their information from, John? And I think the look back on this over the next 2, 3, 4 years is going to be that in general, there were too many people talking, right?
Absolutely.
And so we really need to hone in on the trusted sources of information. So as a scientist, I spend all day long digesting and chewing up like my vegetables, scientific peer-reviewed articles so that I can summarize it for you all.
Sure.
And so one of these ways that we can communicate and get sources of information from folks is through this. But also, I think for the general public, really, really want folks to stick with the CDC, and that's at cdc.gov, the World Health Organization, and any of your local departments of health. They're going to have the trusted sources of information that are based on science as we know it. Next slide. As far as where we're at, I pulled this slide this morning. This is the case rates throughout the United States over the last, almost 2 years now. And, I don't know, could anyone have predicted this? Maybe, maybe not. I think we think about these as waves. And I have a little bit of a problem with that. Sort of a wave is like you think of as an ocean wave is coming at
Sure.
you. That, you don't really have control over an ocean wave, right? This here really is data that represents our choices and policies. And we do have some control over how this is going to look over the next few months.
Wonderful. So with that being said, it's been somewhat difficult to discern truth and facts from misinformation. Can you shed some light on the virus's journey, and how it's been able to maintain such a strong presence for such an extended period of time?
Yeah. So, John, I start that conversation with this slide. And you look at it, some nice colors, but this really visually helps people understand what viruses do. Viruses vary. Okay. So what you're looking at is the family tree from an organization called GISAID. They're genomic epidemiologists that track the development of new variants throughout the world. And in the bottom left-hand corner in orange is the original ancestral strain that we found from Wuhan in 2019. And then this is what the virus has done. This is what the virus has to do all day long, is just figure out how to infect more people. And it does that by mutating and changing. And so this is the family tree. This is what's going to continue to happen. We have a way to stop it or arrest it, and that's with widespread vaccination, John.
So all of those dots there, Dr. Mcgarry, do they represent different mutations and variants?
They do. Yes. Yes. A
Or
fair portion of them we don't care about, but
sure.
some for sure we do. For instance, Omicron, that's going to be upon us pretty quick here.
So, Dr. Mcgarry, is there a number associated with how many mutations or variants there are to date? Last I checked, there was 200 something, and that might have been 18 months ago.
Yeah, I mean, so fair, you're representing thousands of dots here, most of which we don't care about, right? So
Right.
most of them don't have something that gives them biological advantage, so to speak.
Gotcha. So, what are the variants within this table that we should be concerned with that are maybe causing some trouble down the line?
Yeah. So, the virus is going to keep varying so that it can infect more and more people. That's all the virus has to do all day long. Okay. There's generally 5 reasons that a variant gets labeled a variant of interest or a variant of concern. Okay. And
Okay.
it's 5 things that we look at to understand why we should care and what's the difference. And the first one is we want to understand if it's more contagious. Is it more transmissible, is another word. Is it going to jump from you to me more quickly?
Sure.
We also want to understand if it's going to make people sicker, right? Is it going to cause more severe disease?
Absolutely.
We want to know if it's going to evade immunity, okay? And that's immunity developed either through, naturally being infected or immunity that you get from a vaccination.
Okay.
The fourth one is we want to make sure our tests still work, right? We want to make sure that all the PCR testing and the antigen testing we're doing doesn't, say go dark, for instance, right? We want to make sure we can detect them. And then lastly, super important, we want to make sure that our treatments still work, okay? And so for these 5 reasons, we look for all those variants. Some we might not even, just come and go and aren't that important. And some we want to make sure we understand what's going on with these 5 things.
Sure. So what do we know about, let's say, for example, Delta, Omicron, or some of the new variants that you may see making their way over to the Western side of the globe, if you will?
Mm-hmm. So we're still in a Delta wave. So the cases that we're seeing today are still Delta. This morning, on average, in the States, we're looking at about 3% Omicron. So we want to, for Delta, for instance, we do know that Delta is more contagious. We don't think that it necessarily causes more severe disease. We are seeing some waning immunity, both natural and vaccine induced. So we're going to talk later about, folks that are relying on natural infection.
Sure.
Our tests are still working and our treatments are still working. As things change up quite a bit, we might need to change some of the treatments in our monoclonal antibodies. But we've got a good handle on Delta. When we look at Omicron, though, we are just beginning. We're in the very early phases of understanding what's going on for those 5 things, right?
Sure.
The Omicron variant was labeled a variant of concern very quickly, okay? Because it had a crazy number of mutations, over 50 mutations, 32 of which are in a critical piece of the virus on that spike, 10 of which were in an even smaller part called the receptor binding domain that we really look at very carefully.
Wow.
Interestingly, the Omicron variant doesn't come from a Delta lineage. So in that branching that we got to try and stop, it's a whole new family branch. Okay.
Wow.
We know that it's highly contagious. Okay. So some of the estimates in the models are telling us that it's maybe several hundred times % more contagious than the original strain. And if you compare that back, we know that Delta, for instance, was about 70% more contagious than the original strain. So Omicron is holy cow contagious.
Wow.
Okay.
Yeah, certainly enough to raise some eyebrows.
Yeah. Very early on here, again, early days, it does not look like that it's causing more serious disease. We have to be very careful when we interpret that. We sort of just can't take the experience from other countries like South Africa, for instance, or Europe, and just translate it into the States. Our population in the States is a little older than South Africa on average. We didn't experience some of the infection waves that they did and the way they did with certain variants and things like that.
Sure.
But we do know that that the vaccines are holding up. For serious illness, we want to make sure folks are getting their booster shots and getting extra protection. We can talk about that later. But I think the overarching message for Omicron, Jonathan, is we don't need to panic, right? We know what to do. We just need to actually do it, right? So we need to refocus ourselves on the same set of controls.
So it's not necessarily fair to analyze what's taking place across the pond and assume that that's going to be how we receive or experience whatever strand or variant may come across. Fair?
That's correct. That's correct. I think our best indicator throughout the pandemic has been the experience in the UK. So what's going on in England has sort of been preceding what happens here in the States by about 2 or 3 weeks. And so right now we're watching crazy case counts in the UK. So I think we can expect some, pretty quick here, probably by the middle to late of January, things are going to be become pretty crazy here for infections.
I can see that because in the last week and a half, 2 weeks or so, I myself have observed a spike in potential cases, positive cases, breakthrough cases. So there seems to be something coming to light here as we get back into those colder months. People are starting to congregate indoors more often. So it's certainly something to keep our eyes out for.
Sure.
So we're going to take this time and break for an important message. We'll be back in 30 seconds.
Nicholas is the CEO. He's the Chief Excavating Officer. For today, he's the most important person at EDA.
Kids think creatively about what they want to do, who they want to be, who they want to emulate. And this is just another example. Not in my wildest dreams would I think of a construction company that has a lot on their plate to take time out to make a difference in a young guy's life to the extreme.
Welcome back, ladies and gentlemen, to EDA's Safer Together. I'm your host, Jonathan Diaz. We're joined today by Dr. Shannon Mcgarry. So, before the break, you shared some significant information regarding variants and mutations. The constant changing and elusiveness of the virus reminds me of one of my favorite shows growing up as a child, Tom and Jerry. Right? COVID would obviously be Jerry, while us humans would resemble Tom. And all the mutations, variants, if you will, would be representative of the one bulldog who comes into play from time to time, annihilates Tom in the process while letting Jerry get away. I feel like that's kind of what we're dealing with right now. So will COVID be a never-ending game of cat and mouse, or do we have some ways to combat and control this thing?
Yeah, John. So I think the epidemiologic equivalent of the never-ending game of cat and mouse is what we call it when a virus becomes endemic, right? When it's just kind of here to stay. And it is endemic. It's everywhere. I don't think it's going away. We just need to get it down to a point where it's controllable, where so many people aren't getting sick, where so many people aren't in the hospitals. But for sure, we have a way to control it.
Is there a number associated with that, or a quantity that determines we've entered an endemic, or this is something we're going to have to continue to live with from here on out? Is there a benchmark that we're trying to reach?
No. The lower, the better, right?
Sure.
We still have 1,200 people dying every day, Jonathan. I mean, it's a crazy human burden. Maybe endemic looks like a bad flu year, right?
Sure.
Where you've got 30,000 people dying,
Sure.
maybe 40,000. But we've got to learn to live with it. But we do have a suite of controls and some pretty powerful ones as well.
Well, why don't we get into those? Because it doesn't seem as though this thing's going away anytime soon.
Yeah, for sure. So, John, whenever we, as health and safety professionals, as you know, look to mitigate risk from hazards in the workplace, whether they're chemical hazards, physical hazards, or biological hazards. We look to this hierarchy of controls. It's what we've had as health and safety professionals to help us mitigate risk from all manner of hazards. We've had it since the 1950s. The Safety Council and NIOSH put this out through the CDC, and it's been interesting to watch this develop, right? So at the beginning of the pandemic, we came right here and said, okay, what's available to us? What do we know? What we'd like to know and don't know yet. Things have been available to us at different times based on the science. We've made differing recommendations in different sections. I mean, think early on, administratively, everybody was scrubbing everything clean, right?
Yep.
And now we know that route of transmission from dirty hands to eyes, nose, and mouth, we of course want to wash our hands and keep things clean, but we sort of pulled back a little bit on that. A lot of the masking recommendations, we didn't have all the information that we needed to ahead of time. So everybody's just got to be a little patient with us scientists, right? Science is a process, right? It's not this static set of facts, right? So recommendations are going to evolve and change and maybe turn around. And just 10, 11 months ago, we didn't have widespread vaccination available to us as an elimination control. But it is the most powerful tool we have in our toolbox right now.
Wow. So with supporting, other control options, where do we get into? There was talks early on about herd immunity and things along those lines. Could you speak to that at all?
Sure. So when we think about the need for that elimination control as a vaccination, we want to think about how powerful that is. Before I get into that, though, Jonathan, I just want to talk about how important the daily screening is. So when we think about those elimination controls, eliminating the hazard from the workplace is the best way to keep everyone safe. And so we do that most effectively through a daily screening, right? How do I feel this morning? Am I okay to be around anyone? Do I have any symptoms? It's absolutely critical that everyone does that, right? As we get into the next few weeks, and anybody's prediction is anyone's guess. When we think about controlling things, we really got to look to that vaccination. Next slide, Jackie. And so when we think about vaccination, we want to get to that elusive herd immunity. Okay. But what is that? What does it mean? And why do we bother to vaccinate anyone for anything? Okay. So I'm going to get to your herd immunity question. The vaccine is powerful for me, right? I'm vaccinated. Okay. I have protection from serious illness, hospitalization, and death. But my vaccination means so much more to me when everyone around me is also vaccinated, okay? So the true power of vaccination isn't me, really. It's we. It's the we. And that's what the herd immunity concept gets to, which is that you've got enough people vaccinated in a community that you're able to break that chain of transmission, that the virus isn't just jumping from person to person to person. And critically, you're forming this vaccinated wall around the youngest ones, the littlest ones under 5 that can't get vaccinated. You're forming a vaccinated wall around the vulnerable vaccinated, our elderly, the people with organ transplants who took vaccination and just aren't getting full benefit from them.
Right.
That's what we need for herd immunity. What percentage is that we need to have? A lot. It's a lot, right? Nobody really knows exactly. It's 80 plus, 90 plus %. So we'll know eventually, right? When we get this thing, get enough people vaccinated that we can start tamping things down.
So where do we currently stand nationally with respect to percentage of adults or eligible persons having been vaccinated?
Not enough. I mean, that's the flip answer is not enough, right?
Sure.
So we're close to 70% of adults, higher in the elderly categories, which we need to be, but it's just not enough. It's not enough to prevent an outbreak in the other 30% that aren't vaccinated or the people that can't get vaccinated.
Sure. And understandably so, the vaccination has been a hot topic since like you mentioned, 10, 11 months ago. Can we speak to how these vaccines are working? Again, people are having difficulties finding what they believe to be true or not true with respect to these vaccines. Is there anything that you can enlighten us with respect to how they work, the technology, things of that nature?
John, that's a great question. Before we answer how these particular vaccinations work and some of the efficacy and safety data associated with them, I want to just talk about why we bother to vaccinate anyone for anything.
It's a good place to start.
Up 10. Yeah, that'd be great. So, I think a lot of people are frustrated in that they got vaccinated and they're like, what the heck? I can still get sick.
Right.
And so I want to back up for a minute about why we vaccinate anyone for anything. Okay.
Please.
The ideal situation is that we would vaccinate people to prevent any kind of infection. So after you got vaccinated, no way, no how were you even going to get infected. And we call this, it's called a sterilizing immunity. Very few vaccinations actually do this, right? Like your human virus vaccination does this, okay? And that is the holy grail, right?
Okay.
More often than not, most of the time, we vaccinate people to prevent disease.
Sure.
Ideally, we'd prevent mild and moderate disease, but the real goal, the real definition of vaccine success is preventing serious illness, hospitalization, and death. And that's what we need to focus on, right? Because that's what's going to keep people out of the hospital, keep the hospital from being overwhelmed, preventing people from getting care from other things, right?
Sure.
And critically to keep them from dying, okay?
Yes, ma'am.
Lastly, and importantly, we vaccinate people and are vaccinating people hopefully in droves now to stop that family tree from branching. Right? We need to stop the development of those new variants, right? The new variants that are going to do one of those 5 things that are going to start making people sicker, that are going to completely evade protection from our vaccinations, that are going to do horrible things en masse. So we've got to do that. We got to stop that spread through the development, stop that spread of development of new variants through widespread vaccination.
So to your point, Dr. Mcgarry, I think some of the trepidation that we're seeing widespread is probably a result of the notion that some people believe the vaccine is completely designed to shield entirely the ability to, get the virus, transmit the virus. But in reality, that's not entirely the case. We would like to minimize some of those symptoms that would come as a result of the disease and ultimately lower the burden of work and all the trying and commitment from the hospital level, emergency services, first responders. I mean, it's a big burden to carry for 21 months.
Correct.
Awesome. So when we spoke about why do we vaccinate, what are the different types of vaccinations? And is this vaccination any different?
Yeah, that'd be great. So when we think about the types of vaccines that are available to us or have traditionally been available to us, they all work. They all work on the same concept. Okay, vaccines work to train your immune system. Okay, to help you develop antibodies to fight disease critically without getting you sick. Okay, so you can develop antibodies that are specific for SARS-CoV-2, the virus that causes COVID, by getting sick. And we're going to talk about what that means. Okay, Big roll of the dice. A lot of people have been fine. An unfortunate number of people have gotten seriously ill, and a really, really unfortunate, inhumane death toll has occurred. Right. So the important part is to get yourself those antibodies without getting yourself sick, okay? Because it's too much of a roll of the dice, too much of a chance. Next slide. So when we think about that, John, to answer your original question, which is, what are these new vaccines like? How do they work? I want to sort of run through the 4 ways that we've traditionally been vaccinated, okay? You can get vaccinated with a dead virus, right? An inactivated virus. That's how your hepatitis A and your polio shots work. Okay.
Okay.
You can also get vaccinated through a half dead virus, right? Like a live attenuated virus, right?
Sure.
So dead virus or half dead virus. That's how your measles shot works.
Okay.
You can also be given a toxin that the pathogen produces, right? That's how your tetanus shot works.
Okay.
Or the fourth way, traditionally, this is important, you can give someone a piece of a virus, a sugar, a protein, something like this. That's how your hepatitis B series works. Okay, so 4 ways traditionally: dead virus, half dead virus, a toxin, or a piece. Okay,
Yep.
so these new technologies don't do any of those 4 things. Okay,
Interesting.
they are recipes for your body to make a piece of the virus. Okay.
Really?
Do it through 2 different kinds of instructions. There's an RNA instruction and a DNA instruction. We can run through that really quickly. But I put new in parens because these things aren't new, right? We've been looking at these for a long time, right?
Sure.
But we can run through what these new, how these new vaccines work. And you can think about them. The best analogy I've heard is that they're just messages in a bottle. They're just little bits of instructions for your body to do the work of producing the proteins that your immune system can react to. So Jackie, next slide. Oh, go ahead.
So for this particular vaccine, Dr. Mcgarry, there's no half dead virus. There's no dead virus. There is none of the 4 things that you just explained previously. So this is something entirely different. And you hinted towards the fact that you put parentheses around new. How new or old has this technology been around for?
We have been working on this technology for the past 20 years. Okay.
Really?
Yeah. So
Wow.
we've largely spent most of the time figuring out how to bottle the message, right?
Okay.
The coding is the important part, right?
Sure.
Because when we look at how these vaccines work, so in a DNA message, right, which is how the J&J shot works, or an RNA message, which is how the Pfizer Moderna shots work, it was relatively easy to come up with those messages.
Sure.
What was critical was the shell that it comes in. So the shell or the vehicle for the DNA recipe is a hollowed out cold virus. The shell for the RNA platforms through Pfizer and Moderna are fats. Okay. And once you get those, it's pretty basic. That's what's in the injection. They translate to special cells called dendritic cells, and those make the messages in the protein to create a piece of the spike protein. It's not even the whole spike protein, just a little piece. And your body recognizes that as foreign and says, "Oh, I know what to do. I'm going to make antibodies that lock on to that spike protein, that recognize it and mark it for destruction if you're ever exposed in the future."
So that doesn't contain any actual live virus components.
No, does not.
It's simply a message telling the body how to respond in the event that we were attacked by some pathogen with a similar genetic code.
Correct. Yep.
Understood. Wow. And with that, and you said we've been studying this technology for about 20 years. Are there any side effects that go along with this type of technology? What's the safety and efficacy looking like?
Yeah, for sure. So I've got a couple slides on that, John. It's really important. So folks can expect similar side effects to a vaccination for pretty much anything. So a red sore arm, fever, headaches, muscle aches, usually goes away within about 2 days. Shouldn't be anything to be concerned about. It's just sort of your body's natural reaction to building up protection.
Sure.
The medical doctors are asking us to let people know not to take anything ahead of time, like Tylenol or ibuprofen, and these antipyretics. The fact is, the matter is you might not need it. Afterwards, if you do need something, it's okay to take them. But these things, fever, headache, muscle aches, are just a general indication your body's doing what it should be doing.
And nothing to be super concerned about.
No.
Okay.
I do have some concerns that we are actively watching for sure.
Okay.
And we'll run through those really quickly. So I'll just head through the next slides, which is, helping folks get comfortable with what I know, why I'm vaccinated, why my family's vaccinated, and my kids are vaccinated. Okay.
Sure.
And I think one of the things I've been hearing is, oh my gosh, this went too quickly. There's no way this could be safe. But the fact of the matter is, again, we've been studying this for 20 years. Behind the scenes, after September 11th, the terrorist attacks, the scientific community woke up and said, oh my gosh, we had better be ready for acts of bioterrorism. Okay. So at that point in 2001, several agencies globally and within the states were heavily funded to start that basic science research with the express mission of generating vaccines within a 2-month period from new agent emergence to benchtop to arm in 60 days.
Wow.
Okay? And so Pfizer and Moderna had candidate vaccinations within days after they had the original virus sequence from Wuhan. Okay,
Wow.
so this is a scientific marvel. Okay.
So this significantly assisted our ability to react in the moment and at least begin the race to vaccination, if you will.
Absolutely. But
Wow.
there was nothing fast about it, Jonathan. It took 20 years, largely
Sure.
to figure out the coding to protect the DNA or the RNA recipes. Okay.
Gotcha.
So we also know, on this FAST scheme, if we stay with this for a minute, it's just these vaccines are just faster to produce than traditional vaccines. So those 4 ways that I told you we traditionally vaccinate folks take a while, right? So you've got to grow up the virus. If you're going to give someone a dead virus or a half-dead virus, you got to grow up the virus. You have to purify protein. You have to figure out all of these other steps, and it just takes time. Okay?
Sure.
The third reason that things went so quickly is kind of sad. The high prevalence of disease last year in the community allowed us to study statistically outcomes very quickly. So traditionally, when you vaccinate people, when you're testing a new vaccine, you grab a group of people and you vaccinate them. And then you grab another group of people and you give them a placebo or sugar pills. And then you wait. You have to wait a long time, like years, before enough people get sick in each group that you can say, oh yeah, my vaccine worked, right? Within weeks. There was so much disease last year. Within weeks, we understood how highly effective these vaccines were. Okay. We also used our existing networks to combine thoughtfully at the end trials. We used our existing networks also to recruit tens of thousands of people. I mean, these trials had and will be continued to follow 30,000 people in them, 40,000 people. You just don't miraculously recruit. I mean, these are wartime efforts. Okay,
Sure. Absolutely.
To accumulate that many people to study.
Unbelievable.
Yeah. So we also know manufacturing began while the clinical trials were still underway, right? I mean, this would never happen outside of a public health emergency. And importantly, on the safety side of things, we know that it is unusual / unprecedented for side effects to appear from any vaccination more than 8 weeks after inoculation. Okay. And that holds, Jonathan, for anything anyone's heard about autism or Guillain-Barré disease. They've all presented, those things have never panned out scientifically, right? But they've never happened more than 8 weeks, which is why the FDA said to the vaccine manufacturers, don't even put an application in until you've got 3 months worth of data, right? Trial participants. And so for these reasons, plus the surveillance that we've had going on, I feel comfortable with the safety aspects. That said, there are a few things that we're actively watching. We're watching some things very closely, okay? And hands down, we have the most conservative drug approval system in the world. Absolutely.
Sure.
Okay.
I think we could all agree there.
Yeah. And so we're watching things very closely. We're actually able to find needles in a haystack. And so
Sure.
one of our very first pauses was for allergic reactions. So there's some people that are reacting to some things in the shots, either polysorbate 80 or polyethylene glycol usually.
Okay.
And folks generally know if they're allergic to those things.
Sure.
And those things happen within minutes, right?
Okay.
And so if you've got allergies now, you'll be asked to wait a little bit longer than
Yep.
you'll be asked to wait half an hour instead of 15 minutes. Okay.
Sure.
But that was one of our first pauses, and that was happening at about the rate of 2 to 5 per million vaccinations, right? Very
2
rare.
to 5 people per 5 million?
Per
million.
million vaccinations.
Wow.
Yeah. So very
Okay.
rare, super concerning, but very rare. Okay?
Sure.
The next pause we had was on the J&J shot regarding blood clotting risks. And this is generally women under 50 have, an interesting tiny increased risk of developing blood clots. So in the US, it was about 3 cases per million doses. Okay. The difficult thing is that it was this very special kind of blood clot, and the advisory committee on immunization practice had a baseline rate of 10 to 15 cases per million. So it didn't look like in the States that it was much higher risk. Okay. Right. And you can compare this to sort of the other platforms like Pfizer and Moderna. It was 2 cases out of 428 million doses, right?
Wow.
So again, needles in a haystack, super concerning outcomes. Okay. And so if folks are concerned about that, they should talk with their primary healthcare providers. They can switch to the RNA platform. The last one that we're hearing a lot about now in the news is myocarditis and pericarditis. And these are it's inflammation of the heart or the membrane around the heart. Okay.
This seems to be a hot topic these days. We're hearing these 2 terms, almost interchangeably daily.
Right. And interestingly, COVID will cause these 2 conditions, right? But when we
not the vaccine, but the virus itself, you're saying
that the virus itself can cause blood clots and myocarditis and pericarditis. So we got to be careful, when we're talking about, we say competing risks. Okay?
Sure.
But we're looking right now in various age groups. This happens largely, we're concerned younger males. Okay. At about a range of cases from 1 to 10 per million vaccinations, depending on the age group. Okay. In most cases, people have responded well to treatment and rest and had prompt improvements. And so I'm not minimizing any of these things, Jonathan. They're super concerning. For blood clotting and myocarditis and pericarditis, there are actually outcomes of being infected as well. So we've got to think about competing risks. But this is what we've been paying attention to on the safety side of things.
It's a ton of good information, and it goes to show, to your point, finding the needle in the haystack. It's a testament to where we are from a science community, that we can be able to dissect data to that small of a quantity to be able to find these, like you said, diamond in the rough or needle in a haystack type of events. With that being said, in line with what we discussed earlier, how do we know what is true and accurate and what is not with respect to the vaccines? Can you speak to some of the myths surrounding the vaccines and why it's safe?
Sure, absolutely. So, we've been doing a lot of vaccine education and research and trying to understand what's going on. And so here's a list of the major concerns that I've heard. And so we'll hit them really hard. Okay. These vaccines in no way alter your DNA. Okay,
so I won't come out as the Hulk after I get vaccinated.
They can't, right? It's just not biologically possible.
Right.
But the RNA vaccinations, the Pfizer and Moderna vaccinations, they don't even enter the nucleus of your cell where your DNA is located, right?
So you're shedding them after a couple days?
Yeah. So the J&J vaccination as an adenoviral vector, it does enter the DNA, does enter your nucleus of your cells, but it can't incorporate itself into your DNA. It's not biologically possible. You'd need special technology like CRISPR. The fact of the matter is that these DNA and RNA messages are very fragile, right? Remember I said it took a long time to figure out how to message it up, to keep it, to stick around long enough. I mean, that's kind of the irony, is that people are concerned these things are going to stick around and they're going to pass them to another generations. The fact of the matter is the biggest scientific advance was getting them to stick around long enough to generate enough protein so that you could generate enough antibodies. Okay.
Right.
Literally, it's gone within hours to days.
Really?
So it's important to sort of have that context. They can't alter your DNA, can't pass them on to the next generation in any way.
Good to know.
It's also important to remember those 4 ways that I said we vaccinate. People have done it traditionally. These new vaccines do not contain any live virus. They're not going to cause you to get COVID. Okay. They're not going to cause you to have a positive test result either. Okay. And importantly, you can't shed any of the vaccine components. Like, you don't shed antibodies or anything like this. People that are sick with COVID can shed the virus, and that's how that word shed is just the way that which we transmit the virus or infect somebody else. But you're not going to do that with the vaccine or any of the components. Okay. And then critically, Jonathan, I want to make sure that we hit this infertility issue hard, because I've been hearing a lot about it. In no way does any of these vaccines cause infertility, either male or female. Okay. And I want folks to really focus in, if they're concerned about this, if they're planning to become pregnant, to go to the American College of Obstetrics and Gynecology, and you can read through their position statements on this. Okay.
Awesome. Great information.
We also know that the vaccines don't contain microchips or tracking devices. I mean, I think this is kind of, a chuckle kind of thing, but I think some people believe this, right? And they don't.
So
there's apps and websites to track if people have symptoms or signs. They're crowdsourced. They're an early indicator. They result in a database full of associations with the virus, with the vaccination, not causation, right? So there's some of these publicly sourced database like VAERS that people are way over interpreting, but we use them to crowdsource people's, reactions to the virus or reactions to the vaccination.
Right. So what you're telling me is the phone in my pocket has more microchips and tracking devices than the vaccine?
For sure, Jonathan.
You'd be surprised. The world is going crazy these days. There's tons of news out there, tons of information. We're just making sure we get the honest, scientific, fact-based information here.
Yeah.
So with that being said, you can imagine some folks are skeptical and frustrated, right? They feel as though they've done everything asked of them, from getting vaccinated, isolating, masking, unmasking, and everything in between, right? Can you speak to why a booster is needed? Because there's so many people out there who are just putting their hands up, waving the white flag. They're over it. Why the importance for a booster?
Yeah. So the importance for a booster is motivated from vaccine efficacy. And so let's talk about it. So remember, there's several reasons we vaccinate people. Ideally, we prevent all infection, right? We get this elusive sterilizing immunity concept. We, in light blue at the top, you can see how crazy effective these vaccinations have been against preventing infection. And then you're slowly watching some decreased efficacy. Okay. So these vaccines started at 90% effective at preventing infection, right? People weren't going to get sick at all.
Right.
And we're watching over time, we're watching some, which is to be expected, right? That's what happens with our flu shots. The dotted population, critically why we all need to get vaccinated to protect our most vulnerable, that dotted population is representative of nursing home folks. And they never reached that full, 90% protection. They started lower and we're watching it wane. Next slide.
Really?
That's infection. When you look at the rates of hospitalization, again, the more important definition of vaccine success is keeping people out of the hospital and keeping them from dying.
Right.
And the vaccinations are still holding up for that. Okay. We're seeing a little bit of waning, which is going to help motivate boosters. But these things are performing beyond anyone's best expectations, Jonathan.
Wow.
Next slide. And when we think about it, we finally got this data set. It was parsed by, separated by vaccinated and unvaccinated. And this was hospitalization and deaths. So the deaths in this country are largely happening amongst the unvaccinated. So these data run through the beginning of October. And you can see the black line are the unvaccinated folks. So that's the rate per 100,000. That's the death rate per 100,000 among the unvaccinated. Compare that to the blue line, which are the fully vaccinated. Okay. So when we look at these data through the end of September, we'll have end of October pretty soon. They usually lag a few weeks.
Sure.
In September, an unvaccinated person had a 14 times increased risk of dying from COVID-19 compared to a fully vaccinated person. Okay. And I expect this number to rise with this current surge and with the coming of Omicron. Okay. So let me just say that one more time, Jonathan.
Please.
September.
Yes, ma'am.
Vaccinated person had a 14 times higher risk of dying from COVID than a vaccinated person. Okay. And this is so, as a public health practitioner, this just breaks my heart.
Yeah, that's extremely telling. I don't think that there's anything I'm willing to do that's 14 times greater to result in death or serious injury. So it's a very telling sequence of numbers and data and statistics. It begs the question, you know, we're here in the Western civilization. What's next? What's the future looking like? Are we living in the new normal, or is this going to go away?
Yeah, it's not going to go away. And the way we make it go away to a certain livable extent is through widespread vaccination and boosters. So original question was about boosters. Next slide. We saw, you can see that hospitalization, the protection is holding for most folks. We're watching it beginning to wane a little bit for most folks, keeping them out of the hospital. But we know, and I want to be careful and distinguish this from a third dose from a booster, there are some folks that need a third dose now, right? Okay. And they should be working with their healthcare teams. So these are folks that are immunocompromised, taking certain drugs, this kind of thing. They need a third dose soon. They may need it sooner than the 6 months that we're recommending for the booster shots. And so they should work with their healthcare teams. Also importantly, the booster shot from Moderna is half of a dose from the original 2. And so they may need a full third dose of Moderna. So they should work with their healthcare teams. But for most all of us, those over 16, if you're 6 months out from your primary series of a Pfizer or Moderna shot, you're eligible for a booster. Okay. And the kids 16, 17, 18 are going to get Pfizer. Okay. But 6 months out from your primary series, you want to get a booster. If you got the J&J shot, we want those folks to go get another shot 8 weeks after their J&J shot. Okay. We know now that the mixing and matching is safe. And in fact, the folks that got J&J are probably much better off to go get a Pfizer or Moderna shot. Didn't really matter which one. Sure. They're eligible to go get another J&J shot for sure. But we're seeing the biggest boost from switching platforms. Folks that got Pfizer or Moderna, switching their platform to the other could show a little bit of increase, but not enough that it would be worth waiting at this point. Because I know some folks were more keen on the Moderna booster, but it's not as widely available as Pfizer is at this point, particularly on this coast. And I think, the question I get a lot is, are we going to have to keep doing this? What the heck, right? It's just going to be like,
Sure. Every 6 months you're getting jabbed.
Right. The answer to that question is I don't know, honestly, but I do know that, I think we'll get in the cycle like of an annual flu shot. And
Sure.
there's active research to try and just combine those two. But I know the overall need and frequency is going to depend upon stopping that family tree from further branching, right? We need
Right.
to stop the development of new variants. So, to be a little flip about it, the overall need and frequency is going to depend upon how many people we vaccinated last week.
Gotcha.
Right. So,
It's safe to say there's a ton of information surrounding the pandemic, vaccines, and the future. I'd like to take this time to answer a few questions. First question we've got. Does getting the vaccine lower your percentage of catching and transmitting the virus, or does it only lessen the severity of symptoms you may have if vaccinated and contract the virus?
great question, right? Because I think also people were frustrated. It's like, well, what do you mean? I got the vaccination, I can still get sick and give it to someone else. But the answer is you're much less likely to do all of those things, right?
Gotcha.
If you're vaccinated, you're much less likely to get infected in the first place.
Okay.
Although we are seeing more breakthrough infections, which is why we want folks to get boosted.
Right.
If you're vaccinated, you do get infected. There's a couple of things that are going to limit your ability to transmit that to someone else, right? So we
Okay.
know that someone who's vaccinated and infected is going to be less infectious for a shorter period of time, which means you're
Okay.
less likely to transmit it. We also know that the viral load in the infected and the viability of that virus is a little lower in the vaccinated and infected.
Okay.
So you're going to have a little bit lower viable viral load, to say that 10 times fast. You're going to be shorter duration of illness, and you're going to be less symptomatic.
Gotcha.
So you're not going to be able to transmit it as easily. So you're not coughing and hacking all over everybody.
Right.
So for those reasons, the vaccinated infected are less likely to transmit.
So for the viewers, when you mention vaccinated infected individuals, you mentioned that their viral load, if you will, or viable viral load. For the viewers, that simply means your ability to excrete, if you will, that pathogen, that virus, and someone else come on 5-10 minutes later, and like we mentioned earlier in the show, touch that surface, touch their eyes. That's kind of been put to bed or put to rest at this point, right? Not the number one form of transmission.
Correct.
So
Right.
as vaccinated individuals, that viral load that you would transmit is drastically lower and incapable of then replicating in somebody else's system to then get the disease and continue to pass that on and mutate and so on and so forth.
Correct. Yep.
Beautiful. Thank you. So the next question, this is one of my favorites. Does blood type affect the risk of severe COVID-19 illness?
It's a fascinating question. Probably, we don't know, right? Interestingly, during the Black Plague, having O-type blood made you more susceptible, right?
Really?
Versus having type A blood, which was protective for the bubonic plague.
Sure.
And that's how most people in Europe at the time were type O. That's how we essentially got type A blood.
Really?
Right now, for COVID, it seems to be switched very early evidence, not against infection, but against severe disease. So, I don't know, Jonathan. I think, I've had a lot of conversation about why are some people getting so sick and other people seem just fine. And I think the answer to that is going to be very complex set of interactions between
Sure.
people's genes and their environment.
Right.
So they're
Right.
like, what kind of blood do they have?
Sure.
Are they older, younger? Do they have diabetes or not?
Sure.
I think it's going to be a complicated.
There's too many underlying factors and complexities to really narrow down and kind of pinpoint whether one blood type over the other would provide more protection.
Right. In combination with 10 other things about somebody.
Right. Your activity level, your diet, so on and so forth. So that could be a question that we never get answers to because everybody is unique and every system is different. We have reactions accordingly.
Mm-hmm.
So, and kind of jumping off of that, can PCR tests differentiate between COVID-19 and the flu? Because I feel like that may be a big problem coming into the winter. Regular, mild flu-like symptoms, people, possibly getting sent home for COVID. Is that something that we can differentiate at this point in time?
Yes, absolutely, for sure. As well as the at-home antigen kits, which I'm a big fan of.
Interesting.
The PCR is like a fingerprint. It's going to tell
Okay.
you very specifically what, where you are infected with COVID. Okay. And it'll give you a yes or no. You need a different test to tell you if you've got influenza A, influenza B, respiratory syncytial virus, whatever. And we have a flu panel, we call it, that can distinguish all those different things. But yes, the tests that we have for COVID are specific, highly specific for COVID.
So to piggyback off of that again, earlier in the pandemic, I had read, I don't remember exactly where, but there was something that stated the RT-PCR test is able to even detect your level of contagion. Is that accurate?
It is. So the RT stands for reverse transcriptase, PCR, polymerase chain reaction. And what it does is it's a technique in the lab where it takes teeny tiny pieces of the virus and amplifies them. It heats and cools and heats and cools, and it amplifies them.
Right.
So to a level where it can be detected, right?
Right.
So it increases the concentration. The number of times that it's got to cycle to get it ramped up
Determines
tells
the
us
level of contagion.
how contagious you are. So it's like golf, right? It's like you want the lower the number,
Sure.
the more effective you are. The fewer the number of times it's got to cycle,
Makes sense.
the higher the concentration was to begin with. And so, yeah, we call them cycle times. And so we're reviewing it. I mean, this is still early days of understanding a lot of things, and cycle time can potentially relate to infectiousness. We're not entirely sure just yet.
Still a lot of work to be done. Like you said, science is a process. It's not a linear trajectory by any means. So one more question. Can COVID-19 cause severe organ damage? And is there a particular organ system that is mostly or prominently affected by the disease?
Yes and no.
Okay.
So yes, it can cause severe organ damage. And there doesn't seem to be an organ system that is immune from this virus. Early on, I think the thing that's fascinated my clinician colleagues the most is the crazy range of health effects from this virus.
Right.
And at the end of the day, we don't actually think this is a respiratory virus, which is kind of funny.
Interesting.
There's special cells that line all of your blood vessels, your arteries, your veins, your capillaries. They're called endothelial cells. And this virus sets up shop in this endothelium. And depending upon where it sets up shop, it's going to wreak havoc, right?
Really?
So does it set up shop in your kidneys? You're going to have kidney failure. Does it set up shop in your brain? You're going to have a stroke. Or your heart, you're going to have a heart attack. In your toe, right? Remember, everyone had COVID, it is going to shut up and cause blood clots in your toe, right?
Yep.
There's a receptor. It's called an ACE2 receptor that's found pretty much throughout your body, throughout your entire organ system. And that's the key that COVID uses to set up shop. And those receptors are everywhere throughout your body, Jonathan. And so that's one of the reasons this has been so scary.
So there's no red tape for this virus. It has all access backstage, can open any door and wreak havoc wherever it decides to set up camp.
Pretty much. And
wow.
and who it affects more often. I mean, I can tell you, I can run down the list of, sort of things or conditions that make people more susceptible, being older, obesity, diabetes. Like, we've got this list of things of folks that we know that are more likely to have health effects, including men. Men tend to have more serious COVID illness than women. We don't know why. I mean, we'll eventually know why a diabetic, is more susceptible to serious illness, but we don't exactly know why. There's a bunch of theories. In the same way, we don't know why some people have long COVID and others don't. Right.
Right.
So we also know there's people that have long COVID that don't have serious illness to begin with, right? They have maybe a mild case, right? So, that's where we're at. We're very early on in our understanding of a lot of things, unfortunately.
So it's safe to say COVID-19 and the pandemic is giving us a run for our money. We're probably in round 14 of 12, gone into overtime, into extra innings, and we may see some light at the end of the tunnel. It depends how things play out over the next couple of weeks. Like you mentioned, we've got a ton of information to digest here, take back, regurgitate, spread the word. That's all the time we have for today. If there's anything you'd like to say last minute, Shannon, Dr. Mcgarry, now's your time.
Please stay safe over the holidays. I think one of the best holiday gifts we can give to ourselves and our families and our colleagues in our communities is to really consider getting vaccinated. If you haven't already gotten vaccinated, really give it a rethink with the new information that's out there. And if you haven't gotten your booster shots, make sure you check your cards and figure out when you can get a booster shot.
Ladies and gentlemen, a round of applause for Dr. Shannon Mcgarry. Make sure you follow us on LinkedIn and all your other social media accounts. Thanks for joining us this evening. Before we go, we ask that if you enjoyed today's presentation, please like and share. Stay tuned for the next episode. Safer together. Thank you.